All right. Well, we're happy to welcome you here this afternoon on a really sunny and rather lovely December day. Thanks for coming to our monthly presentation of Gray Anatomy. And today we have Dr. Ryan Diddy. He is a urologist. He has been at LMH Health since the fall. And we're really happy that he's here to talk to us today about what you need to know when you need to go, because we all do. I wanted to, before we start, I always like to thank Capital Federal for underwriting retroactive. We really count on them to keep the Zoom zooming and the lights on, so we're grateful to them, and also the Katzmans for their foundation that also supports us. So please go to Capital Federal and thank them for underwriting retroactive. We're really grateful for that. I'm going to just let Dr. Diddy get started. He has his screen sharing up, and as I said, he is new he did some undergrad at Creighton and KU Med, and then back, I think he said to Creighton. I'll let him tell us more about him. But if you're there, Dr. Diddy, we're ready to hear what you have to say, and thank you for being with us today. We appreciate that.
Yeah, of course. Thanks for having me.
You bet.
Yeah, just I'll start by telling a little bit about myself. I grew up in Kansas. I love Kansas. It's great to be back here. I went to Creighton for undergrad and then KU for med school, and then back to Creighton for another 5 years for residency. So it's been a great experience, and I'm really happy to be back in Kansas. Coming to Lawrence has been a new experience for me. I did have a sister who went to KU for KU proper for undergrad, and so I had been here, but it's been a great experience coming and living here and moving here with my family. I have some little kids, so it's always an adventure. Um, and then I've also learned that the Lawrence community is very well educated, which is really nice because it keeps me engaged and interested. And the questions that I hear are really good, thought out questions. So I'm excited to teach you guys some today, and some more things. So some clinical interests that I have that are new to LMH. I've been working with, I have some great partners here, Dr. Heeb and Dr. Klingler. They're great, and I've been able to provide some new therapies for the hospital, which is great. These things include some miniature, less invasive stone surgery, some additional surgeries for prostate enlargement, some penile prostheses for erectile dysfunction. I'm now offering and then male stress incontinence following surgery. And then the big thing I think the hospital has been really waiting for, which you actually had mentioned, is robotic prostatectomies for prostate cancer. So um, I did one of those yesterday, and patient's doing great, and I couldn't be happier for him. And so really happy to bring that to the Lawrence community. So. Let's get started. I wanted to say a little bit about the things that I'm going to be covering is what you need to know when you need to go. I did not come up with that title. That's a great title. Someone else put in the hard work to come up with that title, but it's really good. And I'm going to be covering a few different things. The main focus I was thinking that would be pretty broadly applicable is covering BPH, which is benign prostatic hyperplasia, which is prostate enlargement, and then overactive bladder. So those are two things that a lot of people are dealing with, and so I thought I would focus specifically on those. Let's see if we can, I don't know if someone can mute their mic, but I wanted to go over some definitions. Um, you can read these first few, but urinary urgency is a pathologic condition where you have a sudden compelling desire to pass urine, which is difficult to defer and replaces the normal physiologic urge. And then urinary frequency is the complaint of it occurring more frequently than deemed normal, and it can occur at daytime and nighttime voids. Nocturia is the complaint of interruption of sleep because of the need to urinate. And then urgency urinary incontinence is urinary urgency, but with a loss of urine associated with that urgency. So, and if this seems to be a little bit complicated, I wanted to make it pretty thorough because you guys, you're smart. You can look up stuff online, and so I wanted to kind of go to the next level for you guys and try to teach you something new. So let's move on. So, lower urinary tract symptoms, also known as LUTS, that's the abbreviation. These include symptoms like urgency, frequency, nocturia, weak stream, incomplete emptying. And these can be caused both by the BPH, the benign prostatic hyperplasia, as well as overactive bladder. And these can affect people's lives. Think about how many times a day you go to urinate, and then think about if you had some problems with that, and you can imagine how much this would impact your life. So it's a special place to be to help people with that and to impact their life so much if we can improve that. So let's go a little bit about the role of the urinary system. The urinary system, both the kidneys filter and then the urinary tract drains that filtered waste, and that's what we call urine. You can have issues with that. You can have urinary tract infections, you can have bladder dysfunction, you can have prostate that causes obstruction. And it's really important to keep an eye on this as patients, get older or maybe they have something happen that causes them to have these issues. We see patients from very young to very old with many of these problems. So, so this is an anatomy slide. So I wanted just to go from the top left kind of down. So the top left is a picture of the kidneys. I don't know if you can see my mouse, but there are some red vessels that go feed the kidney, and then kind of the tan, it looks like a drainage tube. That's the collecting system. So this is the kidney collecting system, and then if you look to the right, you can see where that goes all the way down to the bladder. All right. And can you guys see my mouse or no? I'll take that as a no.
Yes.
Oh,
Yes,
you
I can see
can?
it. Yeah.
All right, perfect. Perfect. So you can see this kind of going down to the bladder. This is a female anatomy, and then this is the male. You can see the difference is this prostate is there, and that can cause a lot of issues. Down below, you can see it even more. You can imagine females tend to get more urinary tract infections because the length of the urethra is much shorter, and so the bacteria can get up there way easier. Whereas in males, it has to go all the way up the penile urethra, which is the P channel, and then through the prostate to the bladder to make an infection. And so if we see infections in men, it's a little bit less common. And so it tends to be more indicative that there's something going wrong. So let's move on. So I already mentioned BPH once. It's a non-cancerous growth of the prostate gland that happens over time. And as the gland enlarges, you can see in the figure below that it can block the flow of urine. And this can cause both symptoms or other issues. We have, like urologists have categorized these symptoms into two main categories. We have storage and voiding. All right. And the storage is when your bladder's getting full, the symptoms associated with that. And then the voiding symptoms is when you're trying to urinate and you're having symptoms. Those are those symptoms. So things like hesitancy, dribbling, slow stream. And then let's go to some other symptoms. If you have frequent urination, you could have urgency, weak stream or dribbling, straining, incomplete emptying, stopping and starting. Uh, and these can, if untreated and if it becomes more severe, it can cause bladder and kidney damage, infections, stones in the bladder, or even kidney damage. And so we want to always keep an eye if it's getting out of hand. So some epidemiology, it's very common. So lower urinary tract symptoms affect 40% of men and quite a bit of adults globally. And it's not just that, but it also gets worse with age. So as you age, typically you have more and more prostate issues. Um, and it's not that the young men, they have a prostate, it's just not enlarged. And so I should mention that. I wanted to talk a little bit about overactive bladder. Uh, we already mentioned the lower urinary tract symptoms, but about 11% worldwide are suspected to have overactive bladder, with about 8% of urinary incontinence, and about 22% can't empty their bladder adequately. So, very common. We already went over this, so I'm gonna just move on along. I mentioned it a couple times. I wanted to talk a little bit more about overactive bladder. So, overactive bladder, it's urinary urgency with or without urge urinary incontinence, which is loss of urine, in the absence of a urinary tract infection or some other reason for that. And it's a symptom complex. It's not necessarily a disease. It's kind of like abdominal pain or, a stomach ache or things like that. And so it often occurs with frequency and nocturia, and sometimes you can have urge incontinence. So there's the bladder is really mainly a muscle, and that muscle is called the detrusor. And when that muscle is overactive, it can actually contribute to this kind of pathophysiology, basically why it happens, and it can make you feel like you have to go urinate quite often, and so it can be quite bothersome. You can have this both on its own, or you can have it with BPH as well. Men and women can both have this. Obviously, women can't have the BPH, but they can have overactive bladder. Just turn the light here. Motion activated. And then there are other reasons for overactive bladder as well. Some of the most common reasons for lower urinary tract symptoms are urinary tract infection. You could have some sort of cancer. You could have stones in there. Your muscles could be dysfunctional. It could cause these symptoms. You could have diabetes, could make you urinate more frequently because of all the sugar in your urine. Polydipsia is just a fancy doctor's word for just drinking too much water. So obviously, if you drink too much water, you're going to pee more frequently. And then neurogenic bladder, which is some a cause related to your nerves of why your bladder is not functioning properly. And then there's something called painful bladder syndrome, also known as interstitial cystitis, which is can cause some symptoms as well. Now, it's always good to be evaluated in general for overactive bladder, and that's mainly to rule out some of the other problems. So, we want to make sure that if you have another problem that can be addressed and not ignored. So things that could be surprisingly, things like constipation can cause urinary symptoms. If you're constipated, it presses on the bladder. It's in the same place in the body. It's kind of pushing, it can push on the bladder and really decrease your bladder capacity. Can also just irritate the bladder. And so it's good to stay regular there. And then some of these other things, we did go over some of those. So I'll move on. To evaluate this, it can often be done in a primary care doctor's office. And some of this you can even just think about it on your own. But oftentimes we'll get a urine, or a primary care doctor can get a urine and see if you have an infection. They'll ask you, your symptoms. They'll do a physical exam. Uh, if you're in a urologist office or some primary care doctors, sometimes we'll get a post-void residual, which is a tiny ultrasound machine that scans just your bladder and it calculates how much urine is left in there afterwards. And that can help us tell whether or not you're emptying your bladder well. Um, you can also, we sometimes will catheterize patients one time just to empty out and see how much comes out. But that's usually if we, for whatever reason, can't ultrasound their bladder. And then we can get a urine culture. We can sometimes do voiding or intake diaries, or we'll do questionnaires. And oftentimes we'll do a combination of all these things. So, excuse me. Now we're getting to the part that you guys probably all wanted to hear about is how to actually fix this. Um, so, this is a little bit more exciting. Um, there are a lot of things that you can do in your own life that can help with these symptoms. So whether you have lower urinary tract symptoms or enlarged prostate or just overactive bladder, there are a lot of things that can you can do to help. So just some simple things like going to the bathroom every a certain number of hours. You can set a timer. If you say, hey, I leak every 3 hours, then you can set a timer for every 2.5 hours to go to the bathroom before you leak. And that's called timed voiding. And that helps you ensure that your bladder is emptying adequately to where you aren't having those symptoms or trying to decrease those symptoms. Another thing you can do is double voiding. So what that means is that you go to urinate and then about 5 minutes later you go back, and that can help you empty your bladder more fully than if you just did it once. So bless you. Um, and then another thing you can do is actually, I always joke with my patients, if you avoid if you anything that is enjoyable to drink is going to make your urinary symptoms worse. And I say that not to say that you shouldn't drink what makes you happy, but anything that is other than about water and maybe some flavored non-carbonated water is going to make your bladder more irritated if you have these symptoms to begin with. So caffeine, alcohol, nicotine, sugary drinks, acidic drinks, carbonated drinks, basically anything fun can make your urinary symptoms worse. And that's not to say you shouldn't drink those drinks. Just know that you may have to go to the bathroom more frequently, or you may have more symptoms if you do. So, and then another thing, often patients will say, "Hey, I'm getting up at night. I'm getting up too many times. Is there anything I can do to make it better?" And I say, if you limit your fluid intake 2 hours before you go to sleep, then that can help reduce your nighttime awakenings. Another thing is if you know someone who's very bothered by their nighttime urinary symptoms and they tend to snore, it's also a good idea to get a sleep study because that can cause, if you have sleep apnea, it can actually be the sleep apnea that's causing the nighttime urinary symptoms, not the actual bladder. And so if those patients wear their CPAP, then they'll actually have a huge, drastic decrease in their urinary symptoms at night. So that's always good as well. And then there's pelvic floor physical therapy. Now, this is tends to be more directed towards patients who have been evaluated because there can be many causes, and just doing pelvic floor, for example, if you just do Kegels, some of you may be familiar with Kegels. If you just do Kegels at home, sometimes your muscles that are causing it, they need to be relaxed, not strengthened. And Kegels tends to strengthen those muscles. And so I would just, use that with caution, but know that many times we'll use pelvic floor as a huge help for patients without having to prescribe any medicine. So those are some great things. Let's move on to some of the other things. So, I have a lot of male patients who come in and they say, "Hey, I'm taking saw palmetto or I'm taking this supplement I found at the store." And the American Urologic Association hasn't found that any of these supplements have been shown to help your urinary symptoms, and they may just provide more side effects instead, and they cost money. So, I would. It's not that you can't take what you want to take, of course. It's just it hasn't been shown to work. So um, I wouldn't recommend it just because it doesn't work. So just thought I would mention that because I know there's a lot of commercials out there for supplements, things like that. So we'll go over the BPH medicines kind of, and then I'm going to go over the overactive bladder medicines, just kind of separate it that way. But there are a few BPH medicines. These include alpha blockers, 5-alpha reductase inhibitors, and phosphodiesterase 5 inhibitors. So let's just go into those. So alpha blockers are the most commonly prescribed drug for BPH for really men having any sort of urinary issues. And what they do is they relax the smooth muscle at the bladder neck and the prostate. And that just opens up the P channel and makes it easier to urinate. So these are very good drugs. They're very well tolerated. They start working at about 3 days, and then they reach their full effect at about 2 weeks. So they can a few things they can cause is blood pressure. They can cause retrograde ejaculation, where the ejaculate goes backwards instead of forwards. And then it's good to know for patients who may undergo cataract surgery that they were on this medicine because it can change how the ophthalmologists do their surgery. So very good to know that too. But overall, very well tolerated drugs, and we use it pretty much every day. We are talking to patients who are prescribing this medicine. Um, and then a 5-alpha reductase inhibitor. These include drugs like finasteride and dutasteride. These are they're kind of hormonal drugs. They block the conversion of testosterone to dihydrotestosterone, which is DHT, which is a more potent testosterone that's in the prostate. And it causes, when you give this medicine, it can actually cause the prostate to shrink over about a period of 6 months. Um, it works well. Some of the side effects I've listed down below. It's a little bit, it can have some undesirable side effects. So I always want to talk to patients in detail about the side effects before starting this drug. But it's a very commonly used drug and it works for a lot of patients. So, and then the newer therapy over the last 5 years or so, they've been combining erectile dysfunction drugs um, with BPH therapy. So things like sildenafil and tadalafil. So Cialis is the mainstay of this kind of group of therapy. And what we'll do is we'll give the baby dose of these medicines daily, and they can help both with erectile dysfunction and they can help with BPH, which is the enlarged prostate symptoms. So um, and these drugs are also very well tolerated. And if patients also have erectile dysfunction, they can take additional of this drug on the days they want to, be sexually active, and that can be very effective. So now let's move on to some overactive bladder treatments. I know I'm going probably a million miles an hour, but I want to get through as much as I can for you guys. So, overactive bladder treatment. I know I had mentioned some of these things, just specifically within the scope of overactive bladder, there tends to be a little bit more bladder training things like once you've been evaluated or at least confirmed that you have been emptying your bladder adequately, oftentimes we will recommend some bladder training techniques to allow you to hold off your urination. So when you feel like the urge to urinate, you can actually train your bladder to resist that urge, and over time, that can actually help reset your bladder to where it was before. And that can help some. And we usually have this combined with pelvic floor therapy, and that can be very helpful. So. And a lot of these are kind of geared towards symptom improvement because it's very difficult to fully like cure this this symptoms complex. So if those interventions don't work, then we usually move on to medicines. So we'll go through a few of these. Kind of the historical, most commonly used medicines are what I would consider anticholinergics or antimuscarinics. And this is the list on the bottom right-hand corner of the screen of the medicines within this group. And you may have heard some of these, you may not have, but all of these are within this kind of class. And what it does is it affects the squeezing of the bladder muscle, and it can kind of calm it down. And sometimes it can calm it down a little too much, and it can make it difficult to urinate. But most of the time, patients do pretty well with these medicines. Um, On this middle part of the screen, there's mention that like I was saying, that if you already are not emptying your bladder very well, then I would be hesitant to have a patient start taking this. Um, the side effects with these are a little bit more common. So up to 70% of people who are on this state that they have dry mouth, and it can cause constipation. But I think the bigger thing that just came out within the last couple of years is a black box warning about cognitive decline. And so any patient who is going to be on this for long term, I need them to know that it's been associated with cognitive decline. But more importantly, I usually try to switch them off of this medicine because it's kind of cumulative, meaning the longer you're on it, the more it can cause this. And so any patients over 70, I pretty much will either give a different class of drug, which I'll talk about next, or there's this drug trospium, and it's a little bit different within this group because it doesn't cross the blood-brain barrier. So while it doesn't have any mention online about whether or not it's associated with cognitive decline, if it doesn't get to your brain, then I think it, in my mind, and many urologists would agree, it would be less likely to cause that. And so that's another option, especially if these next ones, sometimes they're expensive. So these next ones are called beta 3 agonists. These ones are a little bit newer. They actually have a different way in which they work. They activate these receptors on the bladder, and this helps the bladder relax. Um, Mirabegron and Virabegron are the two ones in this class. Myrbetriq is the brand name for Mirabegron, and Gemtesa is for Virabegron. So um, these are great drugs. They tend to be a little bit more expensive, especially Virabegron, Gemtesa. Many patients, it's they when we try to give it to them, they say it's just way too expensive. So we'll usually do mirabegron. Now, if patients have issues with blood pressure, high blood pressure, they can raise your blood pressure 10 points. So that's definitely a consideration. So, but these are very well tolerated drugs. There are very few side effects with these drugs. And so they're really clean drugs. So, um, when to refer to a urologist. So I would say anytime you've tried some of these medicines, all of the medicines we've talked about thus far, a primary care doctor is more than excellent at prescribing or talking about or reviewing with you. And many times we won't even see patients until they've failed these medicines or they just aren't getting the effect they want, things like that. And it's always good to remind patients that, urology is a surgical specialty. We do 5 years of surgical training, similar to like an ENT, ophthalmologist, although opthos, I think a couple years fewer, orthopedics, things like that. And so we do see a lot of clinic patients, and we're happy to talk more in clinic. But our main thing is surgery, and so some patients don't know that because um, in the medical side of the kidneys is actually a nephrologist, and so I always like to tell patients about that too. So it's kind of similar to like a neurologist and a neurosurgeon. So I always find that interesting. And so yeah. Um, if you ever see blood in your urine, if you've had recurrent urinary tract infections, if you've had stones, or if you've ever needed a catheter, that's a big reason to see a urologist. Because if there's anything we can do to help, we're very interested in having patients not have catheters if at all possible. So. Some things that we may recommend if you see us in particular situations is some additional testing. Things like cystoscopy, where in clinic we just take a scope and look down into your bladder in clinic. We do this especially for patients who have blood in their urine, and that's just to rule out there's any concern for bladder cancer or things like that. Sometimes we'll do that to see if there are any causes for infections, if you have a large enlarged prostate that we need to evaluate. So that's a very useful thing that we do here in clinic. We also do urodynamics occasionally. This is a test that we use when we are having difficulty teasing out the reason for leakage, especially, and things like that. But most of the time, we try not to order this because it can be quite invasive to patients and quite uncomfortable. And so it's best served in certain situations. So, And then ultrasound, we'll use both the bladder ultrasound, like I mentioned, and then we'll also use a prostate ultrasound to measure the size of the prostate. I wanted to go over just a little bit. We, as urologists, we don't really like chronic catheters because they can have a lot of issues with them. They can put patients at increased risk of urinary tract infections. They can cause, in particular patients, like especially in females, they can actually cause damage to the urethra over time, if they're going through the urethra. They can cause stone formation, things like that. And so, well, there is a catheter that goes through your belly, but it has a similar incidence of infections, things like that. So, just wanted to reiterate that it's kind of a last resort for us, or really like a temporary thing to bridge you to the next therapy. So that's what I would like to say. And then so I did want to briefly touch on some of the minimally invasive surgeries that I do and that many urologists also do. So, and these are for overactive bladder and for BPH. So, um, and I think I was just going to go over the overactive bladder ones. Um, but because the BPH, there are so many different ones that I could give a whole presentation just on those. But happy to discuss if anyone has questions at the end on that. So for overactive bladder, for patients who have failed medicine or they just don't want to be on medicine, that's certainly reasonable. We have a few really good options to help get them, in a happier place. So one of those is a Botox injections. It's the same Botox that people inject in their forehead, things like that, but we actually inject it into the bladder. And what that does is it really calms the bladder down and it can help reduce those symptoms in which your bladder is squeezing when you don't want it to. And patients are very happy with this. It's a minimally invasive surgery. I wouldn't even call it a surgery. I'm actually planning on doing within the next year or so. I'm planning on doing them in clinic, and that's done nationwide very often. With no, we will give some numbing medicine into the bladder beforehand, but no general anesthesia in that setting. Um, and It typically lasts about 6 to 9 months, and then at that point we would discuss whether it was effective and if you would like to have another injection or if we should move on to something else. But a lot of patients really like it, and um, post-operative urinary tract infection, which is treated with antibiotics, is the biggest kind of risk with this. And then occasionally, about 7% of patients, it puts the bladder so much to sleep that they need to catheterize themselves temporarily. But that's mainly for patients who are already at risk of not emptying their bladder to begin with. So, and then the other big one is called neuromodulation. Neuromodulation has been used for years, both in urology and in other fields of medicine. So what it does is it's indicated for urge urinary incontinence, urinary retention, urinary urgency and frequency, and fecal incontinence. And what we do is we place these leads into the sacrum, and they stimulate the nerves that are coming out of a particular part of the sacrum. And with that stimulation, it in a way confuses the bladder into thinking that it's not needing to squeeze. And so the exact mechanism is not fully understood, but it's been shown to be effective. And I have a lot of patients who are really happy afterwards. And the benefit to this one over the Botox is that basically it lasts for however long the battery lasts, which I think they just came out with a 20-year battery. And so you could theoretically have this and then never need any sort of medicine or injections, for a good 20 years at least. So with anything we put in, there can be issues. These are quite rare. I haven't seen some of these ever. and some of them it's extremely rare. So and the other thing is I only see the patients who are having issues. There are plenty of patients who I don't see for many years, so um, patients are very happy. And then there's something called peripheral tibial nerve stimulation. They do this. We do this here. It's in which a needle is placed into the ankle and it stimulates a specific nerve. This you would come in for a 12-week course. You would have to come every week for about 12 weeks, and then eventually you would need some maintenance visits. So um, works for some patients. I think a lot of patients don't want to come in for every week for 12 weeks or for those maintenance courses because it's kind of it's never, it can be kind of obtrusive for their lifestyle, but it's certainly an option. I really, many of the things that I talked about were from the American Urologic Association and these other guideline societies. I won't bore you with abbreviations, but and then just all the years of experience and boards I just took that I'm very happy about. So yeah, I did want to go over. There's a really good website. It's called Urology Care Foundation. It's a really great resource for patients. I think it's actually created for patients from the American Urologic Association. There's a link here, but you could just Google Urology Care Foundation. And it has a really, if today what I talked about was, too complicated or maybe you wanted to learn more, this is a really great resource and it has some really good information on these different things that we talked about and that sort of thing. But I'm happy to answer any questions and happy to help. So,
We did have a question while you were presenting, and the person asked, should nighttime voiding intervals roughly equal daytime voiding intervals?
that's a great question. Yeah, so I actually have extra slides here for some of these. So I was put this here just in case someone asked. So there's something called nocturnal polyuria or nocturia, and it's kind of the idea that if you have greater than one third of your 24-hour urine production during your sleep, then we classify this as its own thing, meaning it's a little bit odd. So you should have less than one third of your whole 24-hour urines during the night. If you have more than that, then there, kind of like what I was mentioning earlier, it could be you have sleep apnea. It could be some heart problems. It could be your kidneys. You could eat too much salt. You could have diabetes, or you could have edema the edema is the fluid in your legs. If you lay up at night, all that fluid could be coming back and being reabsorbed, and then your kidneys could be filtering it and putting a lot more urine in your bladder. And so there are a lot of different reasons. If you notice that your main symptom is the nighttime urinary symptoms, then that's kind of like when you come to see a urologist, we usually will say, hey, it could be your prostate or it could be your bladder, but it's also could be many of these other things because uh, it's kind of like a different diagnosis altogether because it could be so many other things as well. So hopefully that answers your question.
Okay. Any other questions? Here's one. I've been reading about Belcamide procedure for urinary frequency. Can you explain what is involved? Bulkamid.
Yeah, Bulkamid. So that's something I do Bulkamid. So
Okay.
the main indication for Bulkamid is called stress urinary incontinence. So we will see this. It's for female stress and urinary incontinence. So most classic patient that I would recommend this for. Obviously, this is just you know, without knowing anything about the person asking. But most classic patient I would say is a patient who has had typically history of vaginal births, and then may or may not have some issues with prolapse, but the leakage that they are having is with movement. So if you laugh or sneeze or cough or getting in and out of the car, and loss of urine that you don't notice until it's wet. And so it's not like a sudden urge to urinate. It's more of a different type of symptom where it's just leaking. And what the Bulkamid does is it's a kind of a more natural bulking agent that I would put in 4 injections into the urethra, into the P channel, and that bulks up that tissue so that it can keep it shut easier. And that's a very, very minimally invasive surgery. About 70% with of patients with one, maybe two injections are much improved, pretty much cured of their stress incontinence. And so I really like that option for a lot of patients because you're really not burning any bridges, and it's a nice material that will dissolve naturally within about 7 years. And so it's a really good option for a lot of patients.
Oh, there's another question here. What's the connection between heart disease and nighttime urination?
Oh, I could give a whole lecture on that. I could
Well,
give you a whole lecture on that. So it's very complicated, but it's more of like a endocrine physiologic thing than it is actually like a simple plumbing thing. And so um, I would recommend either like looking online because it's going to take a while to unpack that, and it is very complicated. But it basically has to do with your heart producing an enzyme that makes you think you need to urinate more. So that's the short story. And then additionally, you may or may not have some fluid elsewhere in your body that's being sent back to the kidneys at night. But that's a very 10,000 foot view of that. So
okay. All right.
unfortunately, I'm not a cardiologist. So um, what I know is that if you have sleep apnea, I would recommend wearing the CPAP, and that could greatly decrease your nighttime urinary symptoms. And that can be somewhat associated with the heart, but it could also not be. So it's really patient specific. So
Okay. Any other questions out there? I'm not seeing any other questions. Oh, here's one. Is there a correlation between lumbar pain and quick onset of incontinence?
that's a good question. Um, I would have to talk more and ask more about about that question. Because lumbar pain is, I don't know if that is like I don't know if that's with movement or just plain, and I don't know. I'd have to ask a lot more questions clarifying about because there's some spinal if you can't if you're having issues with incontinence and you're having back pain and having especially issues with movement, then that could be a sign that you would need to seek medical care.
Okay. You mentioned, oh, here's another question. I'll try to pull that up. Um, let's see, I'm going the wrong way. Well, here's what's the normal number of times a person should pee every day?
Yeah,
How many
so
times did you have to go?
yeah, so it's highly variable. I would say so the normal bladder capacity is about 400 to 600 milliliters. In medicine, we typically go with the metric system for whatever reason. And so the more you drink, the more you're going to urinate. And there's no like normal amount of urinary episodes, but if it's impacting your life and it's too frequent and then we would call that, lower urinary tract symptoms. But if you're having to urinate, if you're not able to hold your bladder, at least 2 hours, I would classify that, and your everything else is normal, then I would classify that as a little bit abnormal because really can impact your life. It can keep you from going to social events. It can keep you from, going to the grocery store. It really ties you to the bathroom, which is unfortunate. So,
So there's sort of a normal amount, but normal is less only sitting on your dryer.
yeah, I mean, it's kind of like a range, and there's no like set. If you look at um, it's not like if you have to pee every 30 minutes, that's not normal. It's
No,
kind of like it's kind of like if you look at something, you know it's art type of deal.
yeah. Do you have some other questions? You can go ahead and unmute if you'd just like to ask your question rather than use the chat box.
I I don't know how to use the chat box.
Okay.
I'm a male in my late 70s, and I have what I consider to be an overactive bladder. What should a person in my situation be considering or try to do?
Yeah, of course. So I think that the question is, what is the symptom that's most bothersome to you?
Unmute here. Frequency of urination, and I've taken, well, I should say, steps to make sure that I can evacuate my bladder at night uh, using some containers designed specifically for that.
Yeah,
So I don't have to get up and run to the toilet immediately.
yeah. So that's great. Yeah, I always recommend patients who say, "Hey, I don't mind urinating. I just don't like getting up and going all the way to the bathroom." It's always good to have urinals that are by the bed. Things that I would say it's always good to think about how much fluid intake you're having on a daily basis and to make sure it's not just all right before bed. Some patients will do what's called a voiding diary, where they have a sheet and they write down how much they are taking in and peeing out. And when we look at that, we can see, hey, if you're drinking 3/4 of all of your fluid of the day right before you go to bed, then of course you're going to get up at night. And so it's good to always try to drink earlier in the day, and so all of that urine is out by the time it's evening. Now, if you are having a lot of frequency, it may be time to talk to your primary care doctor about whether or not medicine would be good for you to start, especially if you are having some of those overactive bladder symptoms where your bladder feels like it's bothered. I think one thing I would want to know is to make sure you're emptying your bladder. So, many primary care doctors will have a bladder scanner, or they'll be able to tell whether or not you're emptying your bladder. And if you're emptying your bladder well, then it may be time to talk about a possible overactive bladder medicine. And if you're not emptying your bladder well, or it may be in combination with the overactive bladder medicine, it may be time to consider just a prostate medicine as well. And that can surprisingly help with those overactive bladder symptoms quite a bit. If you're able to empty your bladder better, then many times the bladder is it's happier and it doesn't give you as many of those symptoms. So that's what I would say without knowing, your medical history, of course. And um, so
Yeah, that sounds good. There is another question. What would you recommend if a person is urinating every 30 minutes or less, both urgent and frequent?
I would recommend, just for your sake, to see someone, whether that be your primary care doctor or a urologist, because that's no way to live. I think that would just be really, it would impact your life a lot, and I think that that's really tough that that person is dealing with that, and um, I think that's not very sustainable, and it's really, I would recommend someone to come on in and be evaluated.
Mhm. Mhm. That makes sense. Any other questions? Well, here's one. How do you prevent kidney stones?
Oh, that's a great question. The simple thing that I tell a lot of patients is to drink more water and eat less salt. So I like eating out a lot. I like eating out, especially in Lawrence. It has great restaurants, but a lot of the food that you eat out has very high in salt. And so it's really good to keep that in mind and limit some of the eating out because that they sneak salt in. That's why it tastes so good. And limiting your salt intake and drinking more water is the best thing you can do to prevent uh, really all of the kidney stones. Now, there are certain stones that are better prevented with certain medications or dietary changes, but all of the stones do better with more water and less salt.
Mhm. You mentioned earlier, I can't remember the name of for it, but someone who drinks too much water. How
Oh
much
yeah,
is too much?
polydips. So I recommend patients to drink about a good goal is over 2.5 liters of water for those who are trying to reduce stone formation. So over 2 liters is a good amount. Um, like over 2 liters of urine is even better because then you know it's coming out. I don't know what patients doing, like if they're exercising, they may be sweating out more of that fluid.
Mm-hmm.
So measuring the urine is actually better because if you have over 2 liters, then I know that you're getting enough water. But if you drink too much water, there is such thing. It can actually cause you to have low salt, and that's called hyponatremia, and that can actually be a big issue, and that can cause you to get sick and need to come to the hospital. And so, I would say you don't want to drink, too much. Meaning, I don't know if there's an upper limit of normal, but over 4 liters is a lot of water to be drinking. I wouldn't really push it past that. That's just a rough guess because I usually will never have patients who are hitting those numbers.
Hmm. I know I think a granddaughter was working at a startup company in Boulder, and she was telling me they were having the 1 gallon challenge. Everybody was trying to drink a gallon of water. I don't think it was a dare. I think it was maybe an idea that it was going to keep you super healthy. Or have you heard of such things? Or
I've heard of those challenges. I mean, those are the same challenges I hear about people holding their bladders, and it's just kind of that within that realm of, it's supposed to be, some of those are supposed to be healthy, but they can actually be quite dangerous. A few years ago, they did a challenge about who could hold their bladder the longest, and then the person who did, I guess, would win a truck. And I don't, I think I heard that one person's bladder exploded, and that's horrible. And so just don't do that.
hope you don't.
Um, limit, a good judge is if your urine is light, you want it to be like a light lemonade. You don't want it to be like an apple juice. And that
Hmm.
can be a good indicator to see if you're drinking enough water.
Right. Right.
And if it sounds like a bad idea, it probably is. Like,
Yeah.
I've also heard of someone drinking a bottle of soy sauce, and that can put you in the hospital too because it's so salty. It'll affect your salt levels, and that could be actually, life-threatening if not corrected. And so, just, it's common sense is a really good thing to have. And so I always
Yeah.
it's, just try to be reasonable with things.
Yeah.
So,
Think about it a little bit. Here's another question. I always visit the bathroom before a car trip. Invariably, I have the urge to pee again after only 10 or 15 minutes. Why does this happen?
That's a great question. So I would be curious about what it is that you're drinking because most patients would, in response to that, would say, I drink coffee. And it's the coffee, it's the caffeine that will irritate your bladder and make you feel like you have to go pee.
Hmm.
So, and if that's what I would say is the most common. Sometimes patients have their morning, soda or things like that that can also irritate the bladder. So I would keep an eye on what you're drinking before that. But otherwise, there is occasionally just there are patients who have an overactive bladder, and that's just part of the symptom complex. Unfortunately, sometimes is it's just the urge to go, even when you don't have any urine in there. Sometimes, so it may just be overactive bladder.
Okay. And here's somebody who's asking for a little clarification. Is there a recommended number of cups of water per day? Cups.
I wouldn't say cups, but if yeah, I would say 2.5 liters. Let me
Yeah.
just do some quick math about how many cups that is.
Yeah. Normally they say things like 8 ounce glasses, things like that, but I don't know.
So that is 10 cups. 10.5 cups a day is what it would be a good goal of water.
Okay.
And I would spread it throughout the whole day. I wouldn't just chug it in the morning and say, "Oh, I'm done with my water for the day."
Yeah.
Because that's we're talking about trying to keep your kidneys and your body hydrated over the whole day.
And that's water. That's not coffee because the coffee was made with water. That's not tea because the tea was made
Correct.
with water.
So caffeine can also dehydrate you, so that's just
Yes.
something to know. And yeah, so if you're dehydrated, that can also cause kidney stones. I'm assuming that's what that person is talking about because that's how we got started on that conversation.
Right. Yeah. So we're talking about cool, clear water. Just be drinking water. Don't call Coca-Cola. There's water in there somewhere, right?
I have a
Okay.
question, if I'm unmuted, I think.
You
Um,
are.
okay, I have a question. Having gone through uh, prostate cancer 28 radiation sessions um, a year ago, on this side of that, about 9 months, really urinary issues were literally negligible. I was urinating like a 20-year-old, and I'm over 70. And no pain, no blood, nothing like that. But after about the 9 month period, getting close to 2 months ago, started having some pain um, in the urine, incontinence, or frequency more than anything. Almost always made it to the bathroom. But we went through. I'm not sure I can pronounce it correctly. Cystoscopy.
Yeah.
Okay. And nothing shows up in the urethra. Shows a little bit of irritation in the prostate. So I want to be a little bit knowledgeable next time I go back to the urologist, uh,
Yeah.
to ask about the bladder thing, overactive bladder that you were talking about. Because I don't think we got all the way up. I think we just went basically up to the um, prostate. So I don't think we went into the bladder. So would that be a next step type?
Yeah, so of course I would defer to your urologist because I'm sure that your urologist does, great medicine and has a great plan. But it would definitely be worth considering whether um, I don't know whether or not they looked in the bladder, so I'm not sure about that. Most of the time, we will look at the bladder if we're already there, but I'm not sure. What I would say is you've had a history of radiation, And that puts you at risk for something different called radiation cystitis. And what that is the radiation will destroy the tissue around your prostate. And over time, that can lead to the bladder tissue becoming kind of angry and irritated. And that can cause blood in your urine. It can cause really overactive bladder, lower urinary tract symptoms. It can make your bladder quite irritated. And it's a difficult to manage because that tissue isn't something that we can really work with. It's been radiated, and so over time, the radiated tissue tends to get worse and worse. But I do think that it would be worth mentioning, talking about any medicines that might be able to be helpful with that, such as those overactive bladder medicines. I would also be curious about whether urine was taken. I'm sure it was, just to check for an infection,
Good.
especially because it's new. But assuming that they got a urine, I would probably and what I would call probably a negative cystoscopy. It's tough to say because I don't know your history, of course, and what they did on that and how the note looks. But assuming that's all normal, then I would probably move on to treatment to treat you as if you have overactive bladder, probably due to radiation cystitis. But that can take years to show up. You may just be having some post like radiation. Sometimes these will come for a few months after the radiation kind of does its work and then it'll go away. But I would definitely reach out to your urologist, and you may even be able to reach out to your radiation oncologist to see, hey, at what time do your patients have most of their urinary symptoms? Because this may be within the normal scope of what they see on a routine basis. So,
Okay.
Okay.
Thank you.
yeah,
Yeah. Well, I think we're a little few minutes past 5, so um we do appreciate your being with us today. Thank you
of
so much
course.
for everything you've shared. We're getting some clapping hands flying up in the air here for you, so thank you very kindly
Well, thanks
for
for having me.
yeah, thanks for being here, and thank you everyone. And we appreciate your time and your expertise, and welcome to Lawrence.
Thank
And
you.
thanks for being here with us. And thanks everybody for coming today. And we'll see you next time. Thank you so
Yep, you
much.
take care.
Bye, everyone. Drink those.